أهلا وسهلا بحضرتك أستاذ دكتور أحمد سلام، بروفيسور اوف ريتنا اند uveitis at Arkansas University USA. شرفنا حضرتك تشارك معنا النهارده بإذن الله في المحاضرات الأسبوعية الويبينارز الرمديون، وتفضل حضرتك مع حضرتك الميكروفون.
اوكي محمد، شكرا جدا على الدعوة وانا مبسوط قوي ان انا معاكم. وانا هكلمكم على البوستيريور كابسول رابشر والانتي فيتريكتومي. هل في فرصة ان احنا نبقى في انتراكتيف ديسكشن، يعني الناس تسأل سؤال واسمعهم وكده ولا لا؟
متاح. اللي حابب يسأل سؤال يا دكاترة ممكن يعمل ريز هاند أو يعمل ميوت ويشارك. يعني هو احنا الحمد لله في عدد ما شاء الله كبير. اللي حابب يشارك يا اما مثلا لو ما عرفش يشارك بالمايك ممكن يكتب كومنت مثلا في رساله وهنقراه في البرزنتيشن.
تمام، اوكي هايل. هو فالبرزنتيشن ديت هي جزء من كورس احنا بنديه في الاسكرز، وهو اسمه keeping your posterior covered during cataract surgery. فانا حاولت الخص الحاجات المهمه اللي في الكورس ده في المحاضره ديت. الفكره اول حاجه هنتكلم على posterior capsule rupture and anterior vitrectomy. What the question is what to do when you have a posterior capsule rupture. The point is oh I'm sorry okay no okay في حاجات مهمة قوي there are important risk factors for vitreous loss that you need to be aware of. I highlighted here the most important ones. The surgeon grade is something very important. You're expected to have more posterior capsule ruptures if you're a resident in training, and the more you become a senior surgeon, the less the posterior capsule ruptures you will have, because you've, at least supposedly, you've operated more cataract cases. There are other important risk factors like capsulorhexis, pupil diameter, axial lens, and pseudoexfoliation. Talking about axial lens, the classic teaching is that it's a risk factor. If the eyes are more myopic, then your risk factor of posterior capsule rupture is higher. However, in a recent data we analyzed, we didn't find that this would be the case. And we found that if you take out all the associated co-risk factors with myopia per se is not a risk factor of posterior capsule rupture. And then you know for sure pseudoexfoliation. And actually I find more difficult short eyes compared to long eyes. I think the risk factor of the PC rupture maybe is more higher in short eyes than long eyes. But again, I think it's also a factor of what other associated cofactors you have. For example, if it's high myopia with zonular problems, then your risk factor would be higher. If it's shallow antechamber and you have pseudoexfoliation, obviously your risk factor is higher. Let me give you a quiz. So this is a case here. I used to work in England, so this is using an English electronic medical record. So this is a patient I was listing for cataract surgery plus intravitreal Ozurdex, but anyway, just cataract surgery. And then these are the factors here that we put for the patient. So her age, and then we put a factor for gender, then glaucoma, we said no, diabetic retinopathy, no fundal view or vitreous opacities, no. So everything is fine. You know, the patient can lie flat. So what would you think the risk factor would be? The risk factor would be like this. If you're a consultant, it's about less than 2, so 1.33. If you're a trainee with 4 years of experience, then it's about 2. If you're a trainee with less years of experience, it's about 5. And that's what we see for a normal case. It's a routine cataract surgery case. But what if we tick yes for most of these? For example, it's a brown cataract pseudoexfoliation. So brown cataract pseudoexfoliation and a small pupil. What would you think the risk factor would be for a consultant? Can anyone say, just out of interest? Exactly, well done. So for a consultant, will be actually 60% PC rupture. If you have brown pseudoexfoliation and a small pupil. For a trainee, it will be nearly 100%. So I think this risk stratification is important, and it's important for counseling as well, and also case selection. So you know that these cases are not good for junior doctors. Okay, and then this is a summary here that we discussed about the most important risk factors, although I have some reservations about axial length now, in the absence of other associated risk factors. So what pupil size you operate with no mechanical dilatation? And I think this is a factor of your experience. So when I was a trainee, I used to put a pupil ring for all cases. Now when the pupil is maybe 5 millimeter or more, I'm comfortable to operate this without a pupil dilatation, and I think it's safe. But again, it's a factor of your experience and how many cases you've done, and also like, you know, how do you like to do things. But definitely a small pupil is a risk factor for posterior capsule ruptures. Okay, this is interesting. What happens when you think you have a posterior capsule rupture or vitreous loss? You go into this cascade, and I'm sure you all know about it. First is denial. They say, no, it's just a more obvious red reflex. Then you become angry. Why me? You know, it must be the eye. It must be the patient. Why did the patient move? Why did you move? And then you start blaming the nurse, and you blame everyone around you, and of course the resident. And then you start bargaining, where you think, okay, maybe if I manage well, I'll get out of this situation. And then you go into a phase where, why me? You know, what did I do wrong? And then you accept it and you move on, and you think, well, okay, well, everyone knew that I had a PC rupture. Let's just move on and finish the case. There's another thing that happens. They call it the London bus syndrome. I don't know if anyone have heard about this before, but usually you're doing well and you do like many cases without any posterior capsule rupture. Then you have a posterior capsule, and then you start thinking, I'm the best surgeon in the world. I finished the cataract in 10 minutes or less, and I have no complications. Then after that, you have your first PC rupture, so your confidence gets shaken, and you start thinking, no, I'm not actually the best surgeon in the world. I'm not very good. Then, because your confidence gets shaken and you start really like getting worried about everything, you get your second PC rupture, and then you're killed. You think like, I'm terrible, I'm unsafe, and then you would get the third PC rupture. And that, usually this happens to me, that, you know, I would go like great with no PC rupture, and then maybe in two lists or something like this, I get my 2 PC ruptures, and then we start counting again from the beginning. So I think it does happen in a cluster, and I feel this is maybe like you go into a period of overconfidence, underconfidence, and both of them can lead to PC ruptures, in my opinion. So if you have a PC rupture, what do you need to be ready of? I think these are things you need to be aware of and have them available, and at least think about them. So if you have a PC rupture, unless it's happening at the end and there's no vitreous loss, then you will need more time with this case. If you're operating under topical anesthesia, I would strongly suggest that you do a subtenens anesthesia. So you want to know how to do it and have your things ready to do it. Then I would always, even if it's a PC rupture without vitreous loss, I would always stay with triamcinolone if you have this available. I know certain countries you do not have available, or it's expensive. Then you want to be ready with anti-vitrectomy. So you want to know how to set up the machine, because your nurse might be not the nurse or the technician who operates with you every day. And the other thing is you want to know where the probe is, and that's important. Then you need to be ready with a plan B for the IOL. If you have a small PC rupture, you can still put a one-piece IOL in the bag. If not, then you're thinking about the sulcus or an anti-chamber IOL. MyPole is always good to have, or MyStat, and you may want to consider suturing the cornea. Usually I would do suture the cornea. Sometimes I do not, but usually I would do suture the cornea. Then I think what I haven't put here, and very, very important, is you need to talk to the patient. It's very important to tell the patient, you know, in a way what happened. We tell the patient, because it's very important that the patient understands what happened, that you need to follow up the patient. Later on, when you're seeing them, tell them about the warning symptoms of retinal detachment and infection. I usually do not see the patient the first day, but that patient I would see first or second day. And very, very important to be very nice to patients where complications happen. So if you're in a setting where your trainees would see the patients, for example, or your colleague, I would try to see this patient myself and be nice to them, because in case something happens, they always remember that you were kind to them and open. And believe me, even like practicing in a place where litigations are common, for example, in the US, patients do appreciate that you were kind and open to them, and you did not try to escape from them or lie to them. I think this is so important. Okay, let's go more into the details of anti-vitrectomy, but maybe I can stop here for questions. I think that makes the presentation more interactive and more interesting. So back to you here, Dr. Rez, if you have any question or if your colleagues have any question.
يا دكاترة لو في حد حابب يسأل أي أسئلة.
وخليكم فاكرين ما فيش أي سؤال مش كويس أو سؤال يعني ملوش أهمية، كل سؤال مهم. Okay, all right.
دكتور محمد عادل هيسأل سؤال. اتفضل يا
Yes,
دكتور.
please go ahead.
طيب ممكن حضرتك تكتب السؤال عشان المايك تقريبا بتاعك ميوتد، فأنا بحاول أعمل له unmute بس في how to ensure. دكتورة يارا بتسأل سؤال how to ensure that there is vitreous prolapse or not.
Yeah, that's a good question actually, and I think we'll go through it and I'll tell you. That's why you always use Kenalog. حتى لو أنا حاسس إن هو ما فيش vitreous loss. I'll show you what I do. I think we'll have videos on this, but that's a good point. So let's just keep the answer for this until we go through the presentation, the next part of the presentation. But that's a great question. You still can see my presentations, huh?
تمام. في
Okay.
فيديو بدأ.
So here, this is a resident I was assisting, and if you look here, we have a PC rupture. So what did the resident do? You go on irrigation, you start putting viscoelastic, and then you come out. That's what you need to do. So you try to keep the AC inflated. Now here so that's what we do. We put Kenalog like this. And you can see here the Kenalog is falling back. You know that there's a PC rupture. So that's usually a good sign. You can do it with the viscoelastic if you're not sure. You'll see the viscoelastic going back. So that's again a sure sign of PC rupture. With the new microscopes, really you can see it so well. If you practice in a very posh practice and you have intraoperative OCT, you can do an OCT and you can see the rupture. And usually I might joke when someone tells me that we don't have intraoperative OCT, I usually tell them that my son has one at home he plays with. But definitely this is not the case. But we have intraoperative OCT where I operate, so it's nice as well. But this is here what happens. You can see the Kenalog is like really going back. You can see it here very posterior. Now you start. I'll show you. So what you want to do here is at this stage, I would stop at this stage and give the patient a subtenous anesthesia before getting, as they set up for the anti-vitrectomy, I will ask them to get me a lignocaine. and I will give a subtenon anesthesia. And I can show you at the end, if you have time, a video on subtenon anesthesia, how to do it. But it's very simple, and it's easy to do. And I will usually tell the patients we need more time. Things are a bit difficult. We need more time, or something like, if you don't want to say difficult, you can say something that, you know, whatever you want to say. Your lens is playing hard to get, or we need more time here to sort out the lens. Just tell them, because then surgery becomes long and they get worse. So tell them something. That's what I usually do. Then we go bimanual. So this is the irrigation and the cutter. And the rule is you infuse anteriorly and you cut posteriorly. So that I would leave that infusion anterior, and then I will cut posterior, and I may go down to the level of the posterior capsule. And you can see here a wick, which usually happens under the incision because the vitreous prolapses forward. So why did you put viscoelastic from the beginning? The viscoelastic has an advantage and a disadvantage. So here, why do you put viscoelastic? Because if you think about it, there is loss of, when you come out, there will be loss of fluid from the antechamber. So the antechamber will be low pressure compared to the posterior segment. So the vitreous will prolapse. You want to try to decrease the risk or the amount of vitreous prolapse by putting viscoelastic in the antechamber. The problem with the viscoelastic, two things. First, if you put Kenalog, it doesn't stain very well until you start removing some of the viscoelastic. The second thing, it may block the vitreous cutter. So initially, the vitreous cutter will not be working well, and then suddenly starts working well when the viscoelastic is removed. So here, this is infused anteriorly and cut posteriorly, and we even go down to the level of the posterior capsular tear and face posteriorly. The important structure to try to spare here, of course, the cornea and the iris. These are important structure. The anterior capsule is a very important structure. Then the posterior capsule, because you can still put the lens in the bag if the posterior capsule tear is small, or even whether it's central or peripheral. So I try also to spare the posterior capsule as much as I can. And then here, and this is really what I'm going to show you, there needs to be an efficient way to remove the cortex without damaging the anterior capsule. And people do different things here. So for example, they would do anterior vitrectomy, and then they would switch to irrigation aspiration to remove the cortex. I don't do this. I think the best way to do this, and I show you in other videos, is to use the cutter to remove the cortex. But without cutting, because you do not want to cut the anterior capsule. And that's what we're doing here. So we remove the vitreous, and then after that, we would switch the cutter off and think of this as a bimanual irrigation aspiration, and just go and peel off the cortex to the center. If you're away from the anterior capsule, you find vitreous, you can just go to cut. And that's what we keep going. And I'll show you more about this, and we'll talk about it more. So question is anterior vitrectomy better from the front or from the back? Definitely, if you go from the back, you suck the vitreous more efficiently, but it's not an easy technique as you would think. The reason is the eye is usually hypotenuse, so it might be difficult to put the trocar in. Let me show you a few things here. This is a patient who had a zonular dialysis, so he's putting a capsule tension ring, and then we've put a trocar. You see the eye is soft, and that's a problem. You can keep the irrigation in from the paracentesis, and that will make life easy. So here, I've put this, and then I was cutting, and then suddenly I remember that this is not a posterior capsular rupture, that's a zonular dialysis. So if I cut more, I will cut into the capsule. So in this case, I think it's more efficient when you have a zonular dialysis. Otherwise, you're going to cut into the capsules, and the zonular is to go mainly from the front. So hypotony is a problem. If you have a zonular dialysis, you can go from the back, but you still have to go from the front to cut the adhesions here, or the vitreous prolapse. So I cleaned from the back, but there is still that part there, so I'm cutting here. And then after that, you will have to go for that from the front to get it. The question is, if you go from the back, do you use a trocar or just a sclerotomy? We know from performing paraspinal vitrectomy in the old days was conventional without trocars, that there is an increased risk of retinal tear when you go inside the eye, not through a trocar, because you're pulling on the vitreous. So if you put a trocar, it does decrease the risk of retinal tear. So if you're going to go from the back, I would use a 23 trocars, because most of the vitrectors are 23. So I think this is my take. It's more efficient, but it's more involvement. There are high risk of retinal tears, less so if you use a trocar. Hypotony is an issue, so you may want to keep the irrigation from the paracentesis as you put the trocar, especially if you don't put trocars day in, day out. It works for PC rupture, but not so for zonular dialysis. It's less efficient for removal of the cortex because of the angle of the attack. So you'll have to go from the front of the eye still to get the cortex, and I'll show you here. But it's more efficient for vitreous removal for sure. So let's talk here. I'll tell you something interesting. This is a case where there's no PC rupture, so doing bimanual irrigation aspiration. And the reason you can easily go and get the cortex out of the capsular fornix is because the capsular bag is inflated. So it's very easy to identify that plane between the anterior capsule and the posterior capsule. While if the PC is ruptured, it's completely different because that space is collapsed. And that's why it's difficult to find that space unless you're aware of this concept. And sometimes you may be putting your cutter or even the aspiration behind the posterior capsule. And the problem that, the best thing that would happen is nothing, but the problem that you may actually aspirate the whole posterior capsule and the zonular and get a zonular dialysis. So you don't want to do that. So you want to make sure you're in that plane. Once you are aware of this concept, then it's very easy to get into the plane because then you go directly under the anterior capsule, then you're in business. And let me show you this. There's a case here. You have a PC rupture, a big PC rupture. You'll see it in a second. So in my mind, I'm going under the anterior capsule here. And then you peel to the center, and you can see it's peeling off the posterior capsule. Here you're not seeing the irrigation because the irrigation was at the back. That was part of a drop nucleus, and we were going for posterior vitrectomy. But this is the thing here. You go directly under the anterior capsule, you engage without cutting, and then you peel off the posterior capsule. And if the PC tear is small, you can most of the posterior capsule will be also retained, and you still can put a lens in the bag. So how do we do this? This is how I would like you to set your machine. So for anterior vitrectomy, I would go to the highest cutting on the machine, which is in the Centurion here is 4,000. The irrigation is a number you don't need to remember, but basically what you're trying to achieve is that the AC keeps deep. So it's a factor of how you're putting your incision, because definitely if you're torquing your incisions, you're leaking more. But I would keep going high with the bottle or the intraocular pressure if you're using a Centurion until it's enough to keep the AC formed while you're cutting. The suction, usually it's about 300, 350. I wouldn't go more than that because you don't want too much traction on the vitreous. And the aspiration flow is about 10 or 20. If it's slow, you can get this up. But that's how you set. But this is how I want you to set your pedal, because this is important. You want to set it so that here.
Cut enable. Cut disable. Cut enable. Cut disable.
So that's what I would do. When I want to take the cortex off, I would disable the cut. So now it becomes like an IA. And then when I want to go back to cutting, then I would enable the cut.
Cut enable. Cut disable.
And I think this is the most important point in the lecture, is how to use the cutter, because it's most efficient. It's also like very, very helpful. If you have vitreous, you can cut it. And I always think of it like this. لما بيحصل بي سي رابشر بيحصل دوشه في الاوبريتنج روم، فانت لما تقعد تغير من كاتر irrigation aspiration كاتر irrigation aspiration انت بتزهق والنيرس بتزهق والعيان بيزهق وكل الناس بتزهق. يعني كاتر irrigation aspiration والنيرس يعني تقعد توصل وتشيل وتوصل وتركب، فيعني الموضوع بيبقى زهقان. فهو this is a very nice way of dealing with it. اوكي هنا خلينا نحط ده كل ده مع بعض بقى. This is a case where we're doing combined cataract and vitrectomy from the outset. So now what we are doing is we were doing the cataract part, and then we know that there is a PC rupture. That's why we have this 3-port setup. So here, this is my fellow operating. Any case that there is a PC rupture, I will tell you it's my fellow operating. I will not tell you it's me operating, of course. Here, so that's what he did. So we did viscoelastic, we came out. And you can see here, can you see this triangle there? That's the PC rupture, right? So we go from the front because we know that we need to remove cortex from the front. And then this is here. Remember, we're doing as, I think it's the fellow who's messing up the slides as well. Okay, Hannah, remember we're doing 3-port vitrectomy. That's why the irrigation, we're using the infusion cannula in the front. Okay, look at where I put a green circle with a cut rate because that will like be on and off. So هنا داخلين irrigation, right? And the cutting is on. And this is my fellow, he's calling it the world's fastest vitrectomy. But he will show you now why. Because when you go from the back, it goes really quick and efficient, getting the vitreous out of the AC. But still, it's difficult to remove the cortex well from the back. So usually, we can do a bit, but usually go from the front. So now we remove the cortex, we put Kenalog, and all looks nice and clean. A bit more from the front. And here you see there's no cutting. Cutting is off. So now we go and suck it, the cortex, right? And then if you're worried about vitreous in the center, then you go cut again, right? And here changing hand, you want to keep the AC deep. So we'll go from the other side, right? Okay, here you go. So now it's all very nice and clean. And you have the small PC rupture and the rest of the capsule is intact. You can see it here. So now, because this is small, we go and put a lens in the bag. Okay, let me show you. Yeah, I think this is this may not related to PC rupture, but just show you something interesting. That's a dramatic case.
We're staining with trypan blue to look at the capsular defect, followed by Kenalog staining to see the vitreous.
العيان دوت جه في التروما عنده uninsured, so we're trying to finish everything in one go. So هو جه وعنده antique capsule مفتوحة, and we thought also there's lens matter at the back from the B scan. So we decided to do a setup like this. Now we'll stain the antique capsule, as you'll see.
This is the start of the case. We're staining with trypan blue.
Let me just put the... Okay, so stain here with trypan blue, and you will see the antique capsule open. And this is he's 20-something, so we use the cutter to remove the lens matter. And again, the irrigation is from the front. And then we clean. And this is here what I tell you. You have to really have a good position. Then you go under the antique capsule and you peel off. And if there's vitreous, you cut it off. And there was vitreous at the beginning here. Yeah, there was vitreous here, and that's what we cut off here with the cutter. And then we go after that for the cortex. So same as if you have a PC rupture. Okay, now we go to the back of the eye. So we remove the lens matter. We did the posterior hyaloid separation. We found when we're searching, there's a retinal hole there, so we decided to treat this with cryo. Then until they set up the cryo, we were thinking we have to put the lens in. This is an uninsured patient, so it's going to be very difficult to get him back. So we decided to put a lens in the sulcus, but we know that one-piece lens in the sulcus without capturing does not really stay. So then we thought, okay, well, let's do a posterior capsulorhexis. So here is the posterior capsulorhexis. That's the start of it. And then you use the forceps to make an opening in the posterior capsule, which sometimes, if there's a small tear in the posterior capsule, I would convert it to a posterior capsulorhexis to be able to put a lens in the bag. You still can put it in the bag, but it may extend. And then here, this is the sulcus with optic capture, so the lens is stable. And then we went back and we sorted out the back of the eye with cryo and closed. So maybe, I mean, this is a question for you, and then we can maybe stop for questions. So you see me, we've cleaned everything. We're very adamant that you have to clean all the cortex. But sometimes people say if you clean all the cortex, you can cut into the capsule. It doesn't matter if you leave some cortex behind. So my question is to you, and then if you have any other questions, we can pause here for a minute. How aggressive you need to be in removing the cortex in posterior capsule, in a case with posterior capsule rupture. So if anyone can answer the question, and if you have any other questions.
اللي حابب يشارك يا دكاترة يعمل unmute. هو دلوقتي اوبشن المشاركة بقى مفتوح فويس. يعمل unmute لنفسه ويشارك. كان في دكتور محمد عادل رفاعي بيسأل how to tell the patient PCR is occurred intraoperative وبوست operative.
بص، انا في رايي ان اهم حاجه ان انت تبقى هادي في العمليات. لازم تعلم نفسك انك تكون هادي في العمليات. فهو يعني هو احسن حاجه تقولها في رايي الانترا اوبرتيف. ما ينفعش انك تقول له حصل كومبليكيشن وترعب العيان وتبتدي انت تعيط والنيرس تعيط. انا I wouldn't do this. انا رايي ان اهم حاجه في العمليات انت تقول له ان دلوقتي يعني مثلا احسن مهم قوي تبقى عارف اسم العيان. لو انت مش فاكر اسمه، احنا بنكتب اسمه على البورد عشان كتير قوي ما بقاش فاكر اسم العيان. فمهم ان انت تبقى فاكر اسم العيان وتقول له، او تبقى عارف اسم العيان تقول له مثلا يا استاذ محمد، احنا بس قدامنا شويه هنحتاج ان احنا وقت اكتر شويه، فانت يعني قول لي مثلا لو في حاجه بتوجعك او كده. Some communication and some way to tell him or to tell her that there will be more time spent during the surgery. بعد العمليه لازم يبقى عندك طريقه انك تشرح. انا I tell them the lenses the plan was to remove the lens and leave part of the natural lens present so that we can put the lens inside. Now during the surgery that part was open, so we had to tidy up and we still were able to put the lens in. This means that we need to keep a close watch on you after the surgery. We will need to bring you back several times, and when I see you next time I will discuss things further with you. بعد كده مثلا هنشوفك مثلا بكره او بعده، وبكره وبعده بيكون معاهم حد بتقول له بقى اللي حصل. I would try to avoid the word problem. If you can try to avoid the word definitely not a mistake. يعني ما ينفعش تقول اي حاجه على انها mistake او غلطه او كده. I would never say this. Even في ناس بتقول احسن ما تقولش the word complication، مضاعفات. بس مهم انك تشرح للعيان ايه اللي حصل. فانت حاول بقى ان انت تقعد تلعب بالكلام كده لحد ما توصل لاحسن طريقه تبقى مناسبه للمجتمع اللي انت فيه. But definitely as long as you're trained and not negligent, this is not a mistake. It's a complication. And this is a big difference between a mistake and a complication. Yeah. فده رأيي. وزي ما قلت لكم تشوف العيان warn them against symptoms of infection. تقول له خلي بالك لو حصل كذا كذا كذا. تقول لنا غير كده مثلا احنا هنشوفك مثلا بعد اسبوعين، مثلا بعد كده بعد شهر. وانت بتشوف العيان تبقى فاهم انت بتدور على ايه. انت بتدور على كذا حاجه. اول حاجه الانفلاميشن في العين the front. تاني حاجه غير الفيجن طبعا. تاني حاجه انت بتبص على الماكيلا، فلو عندك OCT would be very nice، بالذات لو النظر مش كويس انك تبص على الماكيولار اديما. تالت حاجه بتبص على البريفري بتاع الريتنا تشوف في حاجه وقعت لانس ماتر او في تيرز او ديتاشمنت بتحصل وانت بتشوف العيان. فانت لازم برضه تكون فاهم انت بتبص على ايه. Usually you will give this patient ocular مع الستيرويدز. We use now intracameral moxifloxacin routinely. بس usually بندي العيان ده ocular مع الستيرويدز لأن هم at a higher risk of developing CME. حلو. في أي أسئلة تانية أو حد عايز يجاوب السؤال بتاعي how aggressive you need to be for removing a posterior capsule rupture؟
اتفضل الدكتور عمرو. دكتور عمرو عايز يشارك معانا. دكتور عمرو وليد.
دكتور رزق انت شكلك قاطع عليهم الاتصالات عشان ما
لا
مش
لا،
حد
المايك
يسأل
مفتوح والله، بس مش عارف، هي الناس خجولة شوية.
مش حد يسأل أسئلة معادية أو
دكتور
حاجة
احمد قاسم برضو بيسأل سؤال على البيتيب وسليبنج. المايك مفتوح، اللي حابب الدكاترة يعمل بس جاست يعني سبيك ويشارك مباشرة.
السلام عليكم دكتور احمد، ازي حضرتك يا باشا؟
وعليكم السلام، أهلا وسهلا.
According to your question, I think you have to remove as much as you can cortex in order
Yes.
to decrease the
Yeah.
pencil
هو
reaction post
الفكرة إن
operative.
إحنا بنشوف عيانين كتير قوي عندهم التهابات دايما بعد البي سي رابشر، وده thought إن لو حصل بي سي رابشر العين دي هتبقى lost و they will not do well. I think there are more risk definitely، بس السبب مهم قوي إن العينتين دي العين دي ما بتهداش، إن هو الناس بتسيب كورتكس كتير، والسبب إن هما بيسيبوا كورتكس كتير هو السبب اللي أنا وريته لكم، إن they are not
Yes.
able to identify this plane. Once in enter you understand this and you can identify the plane, I would strongly advise in enter to remove all the cortex. You'll be surprised how the eye settles down so nicely when you remove all the cortex. فدي برضو أنا رأيي كده.
Sorry, I didn't hear you very good.
يعني مهم قوي إنك تشوف الكورتكس كلها.
مش مهم ان انا اشيلها كلها؟ مش مهم؟
مهم قوي إن أنت تشوف
yes very important.
كلها،
تمام.
لأن العين دي مش بتهدى عشان في cortex left behind. If you leave some cortex in an uncomplicated case, a routine case,
تمام.
I think it's fine. But once the case is complex or complicated, زي uveitis أو حصل فيها PC rupture, I think you need to be aggressive enough to remove all the cortex.
طب احيانا واحنا بنشيل مثلا شويه كورتكس، احيانا بيبقى في مثلا حصل زينر ديسنس بسيط عن ساعه او ساعتين، وفي الحته دي فيها حته كورتكس صغيره، وانا ساعتها بقى في ميزان، هل اشيل الكورتكس ممكن يحصل دياليسيس اكتر، ولا اسيب الكورتكس ديت وازرع؟ طب ساعتها اختار ايه؟
Yeah, I think I would still remove it, where by experience you will learn how to first avoid the zoniodiasis happening, and I think the zoniodiasis ده بيحصل عشان الموضوع اللي احنا قلنا ان هو البلين. Where exactly are you going? الحاجة الثانية، the more you know about this, the less this would happen. الحاجة الثانية ان هو الحاجة الثانية and usually even وانت بتشيلها usually zoniodiasis لو انت if you're cautious enough the zoniodiasis does not extend. But I would be careful. I would try to remove as much as you can. I think that sometimes you need to stop. بس يعني مهم قوي ان انت تشيل كل الكورتكس عشان العين فعلا بتهدى جامد قوي، وتبقى very nice لو شلت كل الكورتكس، والعكس صحيح يعني.
طب معلش، وانا لو بشيل اثناء انا بعمل ريموف للكورتكس حته كورتكس وقعت انترافيتريال ورا في العين، طيب هل ممكن انا اسيبها واعوض ده بوست اوبراتيف ستيرويد او سيستميك ستيرويد او كده، ولا انا مضطر اعمل بارس بانفريكتومي واشيلها لو صغير كورتكس بس؟
هو ده سؤال مهم قوي. انت لو تشوف الليترشر بيقول لو اقل من ربع quadrant you can leave it، او اقل من ربع nucleus you can leave it. Honestly in my experience اي حاجه بتقع في العين the eye becomes very angry. I think if it's very very minimal you can watch it، بس يعني if it's not very very minimal, I think in my experience these eyes never settle down. Usually بيبقوا inflamed والpressure عالي، و sometimes they go into problems من البريشر العالي والinflammation and they go into optic nerve problems. So بالذات في العصر دوت الفيتريكتومي سهلة، أنا I would close وريفير لعيان حد يعمل له فيتريكتومي. ده يعني في رأيي. وكتير قوي احنا we do vitrectomies، كتير قوي احنا بنكون already مثلا عيان والليستة مليانة، واحنا already we took time sorting out the vitreous في anterior chamber. We don't convert on table. We say okay we'll close and we'll come back in a week. يعني احنا we can convert on table. بس sometimes يعني العيان بيبقى تعبان وانا بكون زهقت وهو زهق والنيرس زهقت، فخلاص احسن حاجة احنا نقفل ونيجي تاني بعد اسبوع. انا يعني طبعا هو كل الكلام ده فيه cost considerations وكده، بس هو برضو في elements معينه انت محتاج تاخدها في الموضوع كله. السيت اب بتاعك والعيان تعب وانت تعبت، فان انت تيجي تاني I think that's an option يعني. And that sometimes we do this even now more than ان احنا يعني to convert في ساعتها. We used to convert في ساعتها، بس now I tell close and come back in a week.
Yes. شكرا.
العفو. دكتور احمد فؤاد، شكرا على الصوره دي كانت في عين شمس مش كده؟ هي دي كانت في الجامعه في عين شمس.
دكتور أحمد قاسم بيسأل سؤال: how we can deal with remaining cortex material postoperatively when we treat conservatively when to reoperate. بس برضه السؤال كان في حد من الزملاء سأل الفيترس ويك، يعني لو حالة مثلا مش معمول لها anterior vitrectomy well done وفي فيترس ويك مثلا في الاي سي we not affecting ال outcome، يعني هل reoperation or just
هو ده
follow؟
سؤال كويس قوي. انا بصراحه مش عارف ايه الاجابه ليه. اللي انا بعمله كالاتي: لو في فيترس ويك رفيعه قوي this you can cut it with YAG. I think it's nice, it's cool to do it. I think with YAG is very nice. I think it's a low risk even لو ما فيش مشكله خالص. اوكي، لو الفيترس ويك دي مش خط رفيع like a sheet, you cannot cut it with YAG and there's no need to try. مش هينفع. Then you need surgery. And I will not get the patient into surgery unless there is a problem. Problem دي هي غالبا uveitis not settling أو cystoid macular edema أو retinal detachment. هو كده will go into surgery. لكن لو مفيش مشكلة I will not get this patient into surgery. ده يعني that's my conclusion. لكن لو
يعني
هي رفيعة
will be left with مثلا الممبرين بتاع الفيتروس ده just
انت اكيد كلنا شفنا عيانين في vitreous there and T chamber is full of vitreous and they are 20/20. فأنا I would not touch them. لأن أنت ممكن تدخله and you do a great job cleaning up and then the patient gets endophthalmitis. So without a reason I would not. بس لو هي it's like a pencil كده line رفيعة قوي I will cut it with YAG. It's a very cool procedure and I think it's a low risk procedure. لو هي sheet I will not do anything unless there's a problem.
تمام.
حضرتك تروح لو انا بعد ما عملت الفيتريكتوم وزرعت وخلصت الاوبريشن وكله تمام، تاني يوم ببص على العين او بعد يومين ثلاثه والدنيا ستيبل والبيوبل قافله وكل حاجه، بس في شويه فيترس قدام العدسه ما كنتش خد بالهم في العمليه، خد بالي منهم، والعين شاف كويس، ما فيش اوفياتس، ما فيش اليفيشن انتراكرو بريشر ولا اي حاجه، ممكن اليف الفيترس ده عادي؟
ما متهيألي ده اللي احنا كنا بنتكلم فيه.
ما ده اللي بقول
yes.
لحضرتك عليه، باكد
أنا
عليه يعني.
I would leave it. I know it doesn't look very good. والواحد بيبقى نفسه ياخد عيان او يخبي العيان، يا اما ياخده somewhere ينظف كل حاجه بعد كده يرجعه تاني، صح؟ بس انا I would not do anything. لو there's no problem I would not intervene.
تمام، شكرا.
Yeah.
في بعض الأسئلة برضو دكتور سفيان يسأل if pars plan vitrectomy needed it's better not implant and send for retinal surgeon. يعني هو يقصد لو حالة مثلا فيها drop للنيوكليوس أو في حاجة.
Yeah. Can I answer this question a little bit later? لأن هو أنا يعني I'll show you our technique and I'll tell you يعني رأيي في القصة دي.
طيب دكتور أحمد قاسم بيسأل بيقول do you advise early YAG for remaining cortex؟ يعني لو حالة فيها PCR وما عملش مثلا اي للكورتكس بشكل بروبر او كده فلقى في remaining cortex، فهو بيسأل هل ندخل نشيلهم ولا ممكن نعمل ياج ليهم؟
How can you remove the cortex with YAG? I don't know. I don't have any experience. I mean, I think the cortex هي visually affected واتحركت. You'll have to wash it. وهنا then you need to go with anti-vitrectomy. Some in the front is mostly going to be from the back. And that's maybe a one-port vitrectomy from the back هيبقى كويس. And then انت you need to go from the back infusion from the front. I would use a trocar. لكن لو في cortex is not affect الeye مش inflamed قوي والpressure مش عالي not affecting the vision, I would watch it. هي برضو دي حاجة من حاجة شكلها مش حلو بس لو مفيش مشاكل I will not do anything. Yagging الcortex I don't know if that works. مش عارف.
اقصد هو just yag it away from visual axis will be still inside the eye.
بس
لا مش انا.
No, I mean I know no أنا فاهم. أنا قصدي can you yag the cortex away? I don't know. مش عارف.
اقصد هي يعني ان هي تبقى dispersed into vitreous cavity.
مش عارف. ما خدناش دي عندنا في المنهج. أنا مش عارف.
طيب هو تمام. هو حتى الدكتور كاتب just to clear visual access بس هو دكتور احمد سلام not recommend this technique.
يعني
طيب
أنا
حضرتك كنت بتتكلم على طريقة التعامل عند حدوث البي سي ار وكيفية تغيير الآلات.
Yes.
how to tell
رأيي
the
انت
patient how to tell the patient يعني وانا بعمل له ريفيرنج بعد كومبليكيشن عمرو عيد بيسأل
قول
يعني.
رأيي انت، يعني انت لازم بس تلعب بقى بالكلمات، يعني دلوقتي تشوف الكلمات اللي تمشي معاك وتمشي مع العيان. فاحنا بنقول له كده، احنا دلوقتي بنشرح له اهم حاجة في رأيي، اهم حاجة ان العيان ما يسمعش عن المشكلة بس بعد العملية. احنا قبل العملية بنفهم العيان. Cataract is a very successful surgery. However, very small risk of complications. To give you a number, 1% may end up with worse vision or loss of vision. فهو ليه؟ وبعدين نقول له due to infection, bleeding or retinal detachment. أو بعد كده sometimes we cannot finish the surgery in one go, so we need to come back to tidy up, and that's in case some parts of the lens moves to the back. وبنقفل على كده. يعني انا رايي ان انت تبقى very short، بس هو العيان لازم يسمع ان في حاجه ممكن تحصل، ان هو big difference لما يسمع المفاجاه دي اول مره بعد العمليه. even مثلا vitrectomy diabetic patients مهم قوي حاجه عندنا ان احنا لازم نقول للعيان ان ممكن يحصل rebleed after the surgery. هو بيحصل مثلا في diabetic vitrectomy 70% of patients get rebleed. At the end 10% منهم need resurgery. بس هو العيان لازم يسمع كده ولا بيبقى very frustrated. هنقول له okay, surgery would go well, improve your vision, risk of losing vision 7 out of 10 would have a rebleed after the surgery, so don't get frustrated. Usually it will go away, sometimes we need to reoperate. هو بقى فهم ان هو كده مش بيبقى مبسوط، بس هو فهم ان احنا قلنا له. فانا I would find a way to tell the patients برضو قبل العمليه ان في حاجه كده. بعد كده بنقول له دي احنا I don't do this surgery, my colleague كذا هو بيعملها، ويعني I'll try to be there when هي it's a successful surgery they will go and clear up وانا هعرفك عليه. That's what we do. بس يعني I do proceed signal surgery so I don't need to do this, but that's how we teach the residents ان انت تعمل كده وتقول كده ونودي فاهم. ولو في حد anterior signal surgeon بيجي لما العيان بيشوفه بيجي بيكلم ال posterior signal surgeon بحيث ان العيان يبقى شايف ان هو يعني يعني كل حاجه واضحه و it's clear ايه اللي هيحصل يعني. Yeah, السؤال بتاع epinucleus نفس الفكرة. Epinucleus I don't think it's well tolerated. I think it's, unless it's like a minute, I think it's not well tolerated, and I think it's best to arrange for early vitrectomy within a couple of weeks. لما العين تهدى and you can consent العيان we can arrange surgery. ده رأيي برضه.
هل حضرتك بتفضل السكندري اي او ال implementation ولا البرايمري؟
Yes, so it's a good question. أنا في رأيي إن أنت لو مش هتحط IOL in the bag, in the sulcus أو anterior chamber IOL, I would close. I think something like a mani or acris, I think in the primary setting is difficult. The eye is hypotenuse. We usually العملية طولت and I would close and leave the patient awake. I don't think there's a problem in leaving the patient awake. I think المشكلة انك تحط عدسة والعدسة تقعد تتشقلب وبعدين الكونيا تبقى complicated، بالذات لو انت بتشتغل في مكان برضو ما عندكش access للجرافس easily. يعني انا I would close. لكن لو انت decided خلاص سهل انك تحط باج او سالكس والموضوع باين، بالذات سالكس لازم يبقى الموضوع واضح، يعني البيوبل كويس وانت واضح ويور كونفيدنت انك تحطها. لكن البيوبل قفل ومش راضي يفتح وانت مش متاكد اللينس هتركب في السالكس ولا هتقع، I would just close. ده في رايي. لو انت decided ACIOL وخلاص وعندك سيت اب سريع I would just quickly convert واعمل preferadectomy واوسع الوند واحط ACIOL. غير كده I would close and come back.
still use the hard ACIOL UCI.
عيان كبير في السن وما عندوش مشاكل في جلوكوما. I think it's a very good option, very quick, very cheap. I think ان معظم المشاكل بتاعت ال ACIOL, and I have a very nice video على الأكاديمي ويب سايت. one يعني واحد قصير وفيديو قصير واحد وفيديو كبير. I can send you the link. معظم مشاكلها جاي من ان انت بس ما نظفتش كويس الفيترس. I think yeah they do have problems, بس في كذا ريفيو ارتكل بصوا عليهم لقوا ان هي المشاكل تقريبا قد مشاكل سكير فيكسيشن واليماني كله زي بعضه في الاخر. I would not use it in a young patient, but I would use it لو عيان كبير في السن وما عندوش أي angle problem ولا glaucoma. I think it's a very good and a very quick option.
كبير ده اللي هو فوق سن كام تقريبا؟
I think يعني فوق سن 60 مثلا
تمام.
أو 55. I think it's a good candidate. It's very quick, very easy.
طيب في دكتور محمد عادل بيسأل do you recommend dry vitrectomy to avoid overhydration of vitreous؟
لا, I do not recommend. I think يعني I think دي it's a myth إن هو الفيتروس أصلا معمول من 98% مية. I'm not sure how we can hydrate it any further. فأنا I think إن أنت very important to keep the AC deep. If you want to do a dry vitrectomy حاجة بسيطة, I don't think honestly it works well. لأن هو الفكرة إن أنت تحط viscoelastic والviscoelastic blocks القطر. I think dry aspiration للcortex لو أنت عندك I think the scenario that may work well لو أنت عندك PC rupture وcortex remaining وما فيش vitreous فأنت تحط viscoelastic to close the PC rupture وبعدين تروح بزي viscoelastic cannula وتشد الكورتكس ديت من الفورنكس لحد النص كده بحيث انها تخليها بره الفورنكس بعدين تحط viscoelastic تاني تحط الاي او ال وبعد كده تشيل الكورتكس دي اللي انت خليتها more fluffy وانت بتشيل الviscoelastic. I think that works well. Sometimes I do this. لكن لو في vitreous I think you need irrigation.
دكتور محمد عادل بيسأل tips and tricks in how to implant in sulcus avoid dropped eye يعني.
Yeah, I think I have a case I'll show you. أو هشوفه يعني أوريك. I think إن هو في the main tip إن هو ساعات في ال one piece IOL إحنا we use a wound extended technique where we actually just inject in the wound. I wouldn't do this in a 3-piece IOL. I would get definitely with the injector in the eye. And then you need to understand the orientation. Once you've injected the leading haptic in the sulcus and the optic is coming in the sulcus over the tear, then the trailing haptic that you will dial later on هيلف في الsulcus. And I think that makes a big difference. But I think the main thing is to get in the eye with the injector and to also know the orientation. ولو انت if you're going to capture the lens, you do not need to change the power بتاعت lens if you will capture the optic.
طيب في سؤال هو best procedure to avoid a retaining flag مش عارف هل ده related للبرزنتيشن بتاعتنا ولا؟
I can say it very quickly. أنا مش عارف عندي عليه دلوقتي على الكمبيوتر ده ولا لا فيلم. I can try to look very quickly. بس هو أهم حاجة تعرف ال AC is shallow ليه؟ هل AC shallow عشان already ال anterior segment very crowded ولا اللينس منفوخة؟ Sometimes there's a combination of the two. لو ال anterior segment very crowded where it does not deepen مع ال viscoelastic, then you will need to do a dry aspiration من ال posterior segment, and then you put a trocar, you put a cutter, and that's where you do a dry vitrectomy to deepen the anterior chamber. But if the lens is intumescent, the best is to aspirate from the lens. So you go with a 25 or 26 needle on a BCC syringe تحت viscoelastic, and then you aspirate until you start seeing wrinkles. And then it will not extend. Okay, the ACIOL, I have good videos. I'll send them in the share as we speak. Okay, do you want to see the subthetan anesthesia?
تمام يا دكتور.
This we're here. Okay. Can you see my screen, son?
مظبوط.
Okay. هنا هو
This method uses readily available supplies, including an 18-gauge needle, a pair of 0.12 forceps, and a 20-gauge intravenous catheter with the needle removed.
هو ده التكنيك ده أنا يعني للأسف أنا ما اخترعتوش. اخترعه واحد أو يعني عمل واحد في المستشفى كنت بشتغل فيها في إنجلترا. It's very nice and that readily available. This is the IV cannula, 20-gauge IV cannula. and then it just rotates. الميزه كمان ان انت بتفتح الفتحه دي بنيدل كبيره 19 gauge needle، الفتحه بتكون صغيره so you don't need anything really. All what you need is a fixation ونيدل كبيره وال 20 gauge catheter. So I think it's very clever. It's available ويعني الفتحه كمان بتكون صغيره.
We typically administer the block in the infranasal quadrant. The conjunctiva and the tenon capsule are grasped firmly with a downward motion and elevated. A small triangular space of tissue is created. The 18 gauge needle bevel down is then used to incise a small hole in the conjunctiva and the tenon capsule. Without releasing the tissue, the 20 gauge intravenous catheter is then advanced into the subtenon space and the anesthetic is injected. This provides local anesthesia.
I think it's a very nice technique. It's very quick. It's suitable لو حصل PC rupture and you need more time. ده short video. I'll send you the link.
ده لو الحاله كان شغال توبيكال من الاول يعني.
هي دي كانت حاله vitrectomy بس هو this is the scenario. لو انت شغال topical بعد كده حصل PC rupture علشان احسن طريقه I think ان انت تدي بيها انستيزيا لان الموضوع هيطول هو انك تقلب subtenous anesthesia. يعني in my opinion يعني انت ممكن تديله block برضه بس I think ان هو block is messy ودي طريقه سهله I think ان هو يعني انك to block the eye quickly. Yeah, this one is very good. My fellow put this together. It has everything you want to know about the ACIOL, all the tips, all the tricks. I'll put you this as well. Yeah, and we have very nice videos في الفيديو دوت. Okay. ده يعني we'll cover the anterior chamber IOL والselection وكده. Okay, let's go to drop nucleus quickly.
لو سمحت دكتور احمد، طريقه استخدام الانستيزيا ديت كافيه ان احنا نعمل بيها سبترين انجكشن ترايمسون مثلا في حاله المايكرو اديما ولا محتاجه ندخل بالسيرو شويه؟
Yes, you can do it this way. You can do it this way. احنا we do it how دايما نعملها في العياده I don't give it this way. I give it orbital floor like هنا زي sharp needle زي periocular لان هي that's how I do it in clinic. But this way, yes, you can do subtenon this way as well. Okay, how aggressive you need to be in cortical lens matter removal? I think that's where we stopped. I think you need to be aggressive. And if you look at this case, you would think that this is the cortex. You remove it. You can find the drop nucleus. And you think it's done. This is like very small, right? But both the lens factor is small. It's not actually small at all. And you'll see in a minute. You see, and that's why this eye doesn't settle down. And lots of lens matter are left behind. So I'll be like very meticulous in removing the lens matter, especially when the case is complicated. Okay, so maintain the AC deep, infuse anterior, cut posterior. I would use Kenalog, remove all the cortex, 3-piece IOL, a 1-piece in the bag, check for vitreous wick. Let's talk about drop nucleus. If you're an anterior segment surgeon, like this here, this is a case I was doing actually. This is a patient who had a macular hole, had a lens touch. This was like, I think, 10 years back. Well, this is the quickest chop you would ever see. So the stage of denial. No. Definitely it did not drop. Although I know from the beginning that this capsule is definitely open, and I'm the 3 weeks after surgery, gallo white cataract. So definitely the NT capsule. Now don't do like what I've done here. You need to stop and put viscoelastic, then come out. So this is the don't do section. No fishing in the gel. And then you need to address with vitrectomy. This is a case. This is actually a real case. I was operating when I was working in England, and then that patient had dropped nucleus next door. So we wheeled the patient in my room after we finished. So that was like maybe half an hour after his drop nucleus. And you'll see he has actually, once we started the vitrectomy, he has a giant tear. So it tells you that there was some fishing in the gel that happened. This is the ideal case. You have a case who the anterior segment surgeon removed everything, put a lens in the sulcus, captured the optic, put a suture in, and then referred the case to you. So this is the ideal case for a retina surgeon. No vitreous, no cortex, IOL in the sulcus, suture. Drop the nucleus and proud. Okay, posterior segment surgeon, what do you need to do? This is the answer to your question. What size of nuclear fragment is tolerated? In my view, nothing really is tolerated. Hannah, this is very quick. If you have cortex at the back of the eye, you'll see me changing the cut rate. It's not showing. But anyway, you go we change the cut rate. مثلا من, let's say 7000 ل 1000 بعد ما بنشيل الفيترس. That makes it more efficient. And I think it might be, yeah, it's here. You will see it here. Let's just have a look. Just to give you a flavor to what happens. So here we use epi-sugar cane. Sometimes works very well. You see the cut rate here. The cut rate is down there. We'll go down to 1000, and that makes removal of the cortex very efficient. The inhaled cortex is hard, and epinucleus بالذات, it needs more, removing the epinucleus. Then the patient had laser problem. Here, this is a 3-piece IOL in the sulcus. Look, first, you need to get inside the eye with the injector. You don't shoot in the wound, not a 3-piece IOL with the capsule open. Second, you get the leading haptic in the sulcus. Then the part of the optics in the sulcus, and then to compensate, في لفة كده لازم تحصل حوالي يعني 3 clock hours to the left عشان الليدنج هابتك، عشان العدسة تفتح والتريلينج هابتك يبقى معدول. اوكي، يعني هنا يعني انجكتور كان هنا، ادي الليدنج هابتك. اوكي، always remember leading haptic لازم يفتح to the left. بعد كده الاوبتيك، بعد كده حصل لفة هنا كده عشان التريلينج هابتك يفتح صح. And then you wait. Okay, this is a very good situation. لأن هو دلوقتي إيه الوضع؟ leading haptic والoptic are in the sulcus. فخلاص بعد كده أنت لما هتلف الtrailing haptic هو it will drop in the sulcus. هنا كده فهو it will drop in the sulcus. بعد كده that and then you stop. Then the last step is capture. Capture اللي هو تجيب الoptic كده كده. أهو هنا كده. And then كده. Okay. And that's it. So this is now nice. It's the anterior segment is compartmentalized from the posterior segment. The IOL power, effective power did not change. And the lens is very steady. And if you put a lens in the sulcus, it moves. اوكي، دلوقتي انا بقى ردا بقى على السؤال، نحط اي او ال ولا ما نحطش؟ هو المهم انت الريتنا سيرجن اللي انت بتحول له هو بيعمل ايه؟ In the usually the classic ان احنا we introduce the frag like this from the posterior segment. That's usually the classic. احنا we do another technique. Sorry, ثانية واحدة. So this is usually classic. But I don't like it in how you open the you introduce big instruments through the parasplana, so I don't like it. So I came up with this technique, but unfortunately I found some other groups published it. Here, so I go from the limbus. And you don't get a burn, بس هو شوية صعب لأن هو the angle of attack is weird. So بيحصل corneal enfolding يعني it's a bit tricky. You need a bit of a learning time. But I think it's very nice. You don't get phaco burn. And I think it's very nice. But the angle of attack is weird. And then you're introducing the fragmentome. I use the phaco. I don't use the fragmentome. I use the phaco. لان الكيرف بتاع الفيكو ده compensates for this weird angle of attack. يعني دي نقطه مش مهمه، بس I just want to give you a flavor to what we do. So in this case, I tell the patients who refer to me, do not put an IOL because I cannot do it if there's an IOL. That's the only reason I tell them not to put an IOL. And there's no phaco burn. ودي نفس الفكره اللي احنا اتكلمناها. مهم قوي في واحنا when we do retina surgery في drop nucleus ان انا اتاكد ما فيش retain lens matter في الانتير segment ولا في الposterior segment، لان ده مهم عشان العين دي to quieten down. فهو برضو مهم كمان في الposterior segment ان انت تتاكد ان هو ان ما فيش this one ان ما فيش retain lens matter في periphery. So we always search the retina for breaks وكمان retain lens matter، لان هو بالذات لو if you leave the patient operate after 2 weeks بيبقى في retain lens matter near the inferior orisal retina. You need to clean this for the eye to settle down as well. I think again يعني remove all the cortex. If you have something dropped, refer to the posterior segment surgeon. I think techniques زي ال IOL in the back sulcus, or if you have a Clo lens or ACIOL, is fine in the primary setting. Otherwise, I think if you're going to suture to the sclera, I would do this in a different setting. بس يعني happy to answer any question.
دكتور محمد عادل بيسأل بيقول BVD induced in every dropped IOL dropped nucleus.
Yeah, we always try to induce PVD, بس هو يعني sometimes what happens ان احنا we cannot induce PVD, so we try وخلاص بنسيبه. بس يعني يعني usually we try to induce PVD قبل removal of drop nucleus. In any vitrectomy we usually try to induce PVD, but sometimes it's difficult. You try it خلاص هيبتدي يحصل بقى تعمل damage للretina, then you stop. Any other questions?
ممكن حضرتك تكلمنا يا دكتور احمد عن مسيرتك في انجلترا واليو اس اي في
تجربتي في انجلترا؟
لا حضرتك يعني عرفنا بس، يعني ادينا كده، يعني حضرتك احنا من البيج نيمز اللي بنسمع عنها دايما، بس مش كل الناس كانت متابعه من البدايه، يعني فحضرتك عرفنا بقى يعني موضوع السفر ومثلا ان حضرتك خلاص تشويس مكان معين وسب سبيشاليتي، يعني في يعني دردشه كده في 5 دقائق او في 10 دقائق كجزء سوشيال.
اوكي، انا كنت في جامعه عين شمس، كنت نايب، بعد كده مدرس مساعد، بعد كده في سنه 2005 كنت عايز اروح اتعلم I used to do يعني comprehensive ophthalmology وبلاستكس، كنت عايز اروح اتعلم orbital surgery في انجلترا. بعدين ما كانش في فرصه، فروحت اعمل uveitis research، وبعد كده جالي orbital fellowship بس بعد سنه. بعد كده وانا بعمل uveitis research اتلغت الاوربيتال fellowship دي، قالوا لي ان هم they cannot fund me ومفيش فلوس، فيعني خلاص. فقلت خلاص انا عجبتني فكره اليوفيايتس، فقلت هحاول ادور اعمل يوفيايتس والريتنا، فقعدت اعمل يوفيايتس والريتنا. عملت كذا fellowship medical retinal surgical retinal uveitis and then I equated my training، وبعد كده بقيت local consultant سنتين، بعد كده substantive consultant لحد 2016. بعد كده زهقت لان اليو كي سيستم قلب شويه زي مصر، ان انت محتاج انك تشتغل في المستشفى وتشتغل برايفت براكتس، تقعد تتنطط من هنا لهنا، فحسيت الموضوع زهقت. فبعدين قررت اروح مكان تاني، فكان ليا اصحابي في امريكا في مقاطعه، فقلت اوكي انا هحاول اروح المقاطعه دي. هم كانوا عايزين يوفيايتس وريتنا سبيشالست في الوقت ده، فاي went to امريكا اركنسو and I'm very happy هنا. وبعدين اصحابي even مشيوا راحوا حته تانية وانا فضلت قاعد هنا. بس هي ده الملخص. بعد كده we're trying to improve the program هنا، ف now we're 9th on the nation on research output. We have a strong residency program where it's even improving. I've been the program director للرesidency من 3 سنين وبس يعني ده اللي احنا بنعمله. We're trying to improve resident research, resident experience, resident training وده الانترست بتاعي.
ما شاء الله، لا حاجة مشرفة جدا دكتور. واحنا نتشرف ان حضرتك يعني تشير الحاجات الجميلة الريزيدنس بروجرام والحاجات دي بين بعض النواب برضو، لو حابين يطلعوا مثلا او يحاولوا يطبقوا الحاجات دي مثلا مع نفسهم او كده في المستشفيات بتاعتهم. يبقى كويس جدا ان احنا نستفيد من خبرة حضرتك يعني.
والله يا ريت، انا تحت امركم في اي حاجه. انا في رايي الشخصي ان احسن resident training is in the UK، ده رايي يعني. And I think the resident training in the UK is very strong. The US is strong as well، بس هو النمبرز اكتر في ال UK وال residents do more in the UK. انا عارف ان دلوقتي ال UK فاتحه عشان كل التغييرات في السيستم والبريكزت وكده، فرايي اللي عنده فرصه ان هو يروح ال UK يشتغل وفي السيستم يعني مش لازم يقعد. I think it's a very useful experience. I think the UK in training is fantastic. واسهل من امريكا، و I think ان هو يعني فعلا كويس. ولو في حاجه اقدر افيدكم فيها انا تحت امركم. يعني انا بشتغل يوفيتس وريتنا and I do complex cataracts و anterior segment surgery برضو.
متشكرين جدا لحضرتك يا فندم، وكانت محاضرة جميلة وشيقة. واستاذن حضرتك بس في الزملاء بعد المحاضرة لو حد مثلا عمل بعض الأسئلة ممكن نرسلها لحضرتك.
طبعا تحت امركم. انا اشتركت في الجروب ان شاء الله، ويعني I hope I could contribute، وتحت امركم في اي حاجه.
متشكرين لحضرتك يا فندم، وإن شاء الله لنا لقاءات قريبة بإذن الله.
خلاص ان شاء الله باذن الله.
شكرا.
متشكر أوي. السلام عليكم.
وعليكم السلام.